So now let's begin our journey. To start this morning, we will actually take one step back and look at the bigger picture. Before we move into the current lived experiences and current community responses from different countries, we need to remind ourselves what harm reduction actually is and how it actually started for all of us in the world back in 60s, 80s, and 90s. It is my true honor to introduce to you Professor Jerry Stimson. Jerry is one of the leading figures in the history of harm reduction and public health in the world. His work has helped shape the programs we understand now as drug harm reduction programs and HIV prevention programs around the world. And his work let us understand that harm reduction is not an abstract concept. It is a very concrete public health approach based on evidence and the values of human life. He is also one of the founders of the Knowledge Action Change, the organization that I also represent here today. Jerry, thank you for being here with us, and the floor is yours.
Thank you very much, Tatiana. I'm kind of the surprise speaker, not in the program, but it's very kind of you to let me say, I was going to say a few words, it'd be rather more than a few words about harm reduction and where all this fits with our interest in tobacco. So sort of a quick run through of my experience of harm reduction and how it relates to what we're all talking about at this conference. Thanks very much for bringing us all together, very kind of you. And Tatiana's done wonders in trying to bring issues of tobacco harm reduction to new sectors and regions. So I'm very grateful for the work you've done. So making drug use safer is harm reduction, making sex safer is harm reduction, and making nicotine use safer is harm reduction. So it's quite a simple message this morning that tobacco harm reduction is harm reduction. It shares all the principles and values of other harm reduction practices. It's relevant to all smokers, but it's also relevant for services serving special populations where there are very high rates of smoking. Services for people using drugs, for people with HIV, people with TB, reproductive health services, services for sex workers, mental health services, services working with migrant and displaced persons, and working with those in poverty, all where there are elevated rates of smoking and where smoking is often seen as either disregarded or seen as rather difficult to tackle. So why my interest? Well, I've got a long career as an academic studying social aspects of drug use, and Tatiana very kindly mentioned how long I'd been around, but I've done several decades of research on drug use, and increasingly saw that as related to harm reduction, although that term harm reduction didn't appear until the mid-1980s, 1987. So I got interested really in harm reduction through my work with looking at social aspects of drug use. So harm reduction is at one level incredibly simple. We all do it. There's all risky things going on around us in our lives, and we all take measures to avoid risks. One of my favorite harm reduction examples is driving personal motor vehicles. You know, we don't try to stop people driving. We try to discourage driving, but we don't try to treat people's dependence on driving. But what we do is make driving safer for drivers and people around. We, through road design, through driver training, through education, and separating out risky behaviours when they come together. Double the risk, drinking and driving. So reducing risk is an interplay of four things, and it depends on which area of harm reduction we're looking at, but it's about design of products or accessibility of safer products. It's about the risk environment, where people are exposed to risk. It's about people and their behavior. the information and resources they have about risk. And it's also about policies and regulations to help people be safer, or sometimes not. Harm reduction is sometimes defined as policies and practices that help people lead safer lives, but we should actually put people first, because it's people who do harm reduction, and it's governments and other agencies that or often, as the case may be, stand in the way. So harm reduction is basic public health. It's also a human right. It's the right for people to have the information and circumstances and the resources to lead healthier lives. So harm reduction is easy, but of course, when it comes to drugs and sex and communities that would benefit from harm reduction, there are huge obstacles, which include stigma, hatred, intolerance, deprivation, impoverishment, abuse of human rights, and prohibitions on safer products. So although harm reduction is easy, it's also not easy. So where did it start? Well, I think we often think of it starting in the 1980s with the arrival of HIV/AIDS, but there's a much longer history of harm reduction, although it wasn't called that. For example, in the UK, doctors were able to prescribe heroin to people addicted to heroin from the 1920s. In fact, there's 100 years of that policy. Still a few people are prescribed heroin, but that was done explicitly in order that people would lead relatively normal lives whilst using the drug to which they were addicted. Now, that continued in the UK through to the late 1960s, early 70s, and my first research was actually on people who were being prescribed heroin in London, and my research contributed to some understanding of the sort of people that would help. A bit of the puzzles. It helped some people it didn't help. It was also the time, this is early 1970s, when I became involved with one of the first community drug projects in London, which was aimed at giving sort of day care, day service, just a safe place for drug users in a community in South London. Many of them were being prescribed heroin, and they used to inject in the local park, but the centre was set up as a place that they could go to, which was a benefit to the drug users, but also benefit in a way to the other users of the park. And the person who developed that project, Susan Martin, described it as a place where people could spend time without fear of harassment, she said, and also to have a chance to join in a community which doesn't reject them and which it hopes they will not find it necessary to reject. So early on, I sort of realized the importance of making contact, reaching out to people, providing safer spaces, offering help without excessive demands and expectations. So harm reduction is more than health and safety, it's also compassionate. It's what someone once described as the opposite of stigma and hatred. Thinking back to that period in the early 1970s, I remember now that we had a space in the community project where people could inject. It was probably the first fixing room, first safer injecting room to operate in the UK. It didn't last that long for a number of reasons, but it was an aspect of saying, people are going to inject, where can they inject? Can you make a safer environment where they can inject? Skip forward to the 1980s and the arrival of HIV and AIDS. The HIV antibody test was introduced in 1985, and within a year, it was soon realized that many people who inject drugs were HIV positive. Some of the early testing in the UK found, in particular in Scotland, that up to 50% of people who injected had become HIV positive within the space of a couple of years. Very rapid spread of HIV infection. So alarm bells, and similar reports were found around much of Europe. And the UK was one of the first countries to make needles and syringes available to people who inject. And I was brought in by the UK government to evaluate that project, and it was very successful in contacting people, helping people change their behaviour. And the UK, as a consequence, has had an extremely low level of HIV infection amongst people who inject drugs. A side note, the first needle exchanges were not developed by local projects or by governments, but were developed by in the early 1980s in Rotterdam by the Rotterdam Junkie Bond. The Junkie Bond was a union of drug users who persuaded the city to make needles and syringes available to them in order to curb the spread of hepatitis B. So again, it's often affected communities that start harm reduction and do harm reduction. It's not experts who do harm reduction. So in 2004, I had a bit of a crisis moment and gave up academic research. I thought this was a little bit boring and I'd made a poor career choice, so there were other things to do. So I went then to run the International Harm Reduction Association, which was later called Harm Reduction International, which was there to persuade UN agencies of the importance of drugs harm reduction, many of whom were against drugs harm reduction. United Nations Office on Drugs and Crime always had a difficult relationship with harm reduction under pressure, partly from the US government, who was a major funder. WHO rejected drugs harm reduction. Conference that we held in Switzerland, WHO staff were banned from coming because it was about making life, about reducing harm to drug users. But anyhow, that all changed over time. And whilst at International Harm Reduction Association, we were very lucky to have a grant from the UK Department for International Development, and we used that money to seed the development of many organisations, including Input. We were the first funders of Input, and also Manara. We were the first funders of Manara, and Youth Rise, and a number of other things that have gone on to have quite successful lives since then. So I came to tobacco harm reduction from drugs harm reduction, and kind of why tobacco harm reduction? Well, firstly, the sheer scale. I mean, nicotine is the world's most popular drug, well, alongside caffeine and alcohol. It's one of the top three drugs. Over 18% of the adult population smokes tobacco. There's nearly 1 billion smokers globally, and insufficient progress has been made by national governments and international organizations to help bring an end to smoking. Smoking annually kills more people than HIV, TB, malaria, and illicit drug use. That's a bit of a sobering thought because a lot of our work has been in those areas, but smoking kills more people than those areas combined. The problem is that when you burn tobacco, it releases thousands of chemicals and causes high levels of morbidity and premature death. The way in which tobacco control has developed has been to focus on reducing demand and reducing supply, aiming for a tobacco-free world. And you might see how that resonates with people who want to create a drug-free world, so a vision that there'll be no tobacco, no smoking, that it can be made to disappear by making it difficult to produce and sell, taxing it, and making life difficult for smokers. And when I came to tobacco harm reduction from drugs harm reduction, I was stunned that public health people would talk about stigmatizing smokers as a way of helping them. You know, all the work that's been done in drugs and AIDS and everything else is all about destigmatization. But here you have public health people saying, you know, encouraging hatred of smokers, encouraging dislike of smokers. So too many sticks and not enough carrots. So the cigarette, it's a dirty delivery system. And in a way, there were not many opportunities, not many harm reduction opportunities until the invention of the e-cigarette in early 2004, which kind of changed the game. People could now enjoy nicotine with a vastly reduced risk of harming themselves. So recreational guilt-free nicotine use was now possible. So there are now many nicotine delivery systems, vapes, nicotine pouches, Swedish snus, heated tobacco products, all substantially safer than smoking. So people can now use nicotine in a way that won't kill them. So part of what's been driving this has been consumers. The early days of tobacco harm reduction were just, were community initiatives, community smokers' choices. Little organization there were vape fests, there were online fora offering advice, but that's grown to a proliferation of the dozens of vaping advocacy groups worldwide. So the outcome of this is that where tobacco harm reduction has been accepted and tolerated, there have been major reductions of smoking, and there are lots of good examples in the UK, for example, in New Zealand, in Sweden, Norway, Japan, Iceland, where smoking has just dropped. In fact, in some of those countries, vaping or the use of other drugs, other types of tobacco, such as snus, has overtaken. There are more vapors in the UK now than there are smokers. But there are problems. WHO supports drugs harm reduction, but runs misinformation campaigns about safer nicotine products. You can't trust WHO on this topic, and that's difficult for many of us who've had long histories of working with WHO. US foundations campaign against tobacco harm reduction. The same foundations support drugs harm reduction. The lead International Harm Reduction Association is scared to engage with tobacco harm reduction. So this disconnect between drugs harm reduction and tobacco harm reduction plays out, I think, in many sectors. Probably plays out at a service level, in drug treatment services for sure, in services of HIV, I guess, in TB services, and so on. Now, amongst drug-using populations, there are hugely high smoking rates. Our recent bit of research with Attica in Kyrgyzstan found that nicotine use was almost universal. 99% of drug users in touch with harm reduction services in Kyrgyzstan used nicotine, and 80% were smoking. And that was the same for men and for women. And for women, that's an extraordinarily high level of smoking, because the background level of smoking in Kyrgyzstan is about 3%. So amongst women, female drug users, the smoking rates are 25 times the national average. So I think as we start to explore issues of women and smoking, we're going to find that in mainly smoking is a male issue. Explore why that might be the case. But in special populations, very high levels of smoking. And smoking now appears in some studies to be as responsible for as many deaths amongst drug users as drug use. A recent study in the UK of 100,000 heroin users, following them over time, found that the mortality rate from amongst drug users, heroin users from smoking was around 28%, and death rate from smoking amongst that population was 24%. So again, that's quite stunning. We focus on drug-related deaths, but smoking is also a cause of death. So whilst this is all going on, I think services have often either disregarded smoking or found it one of those things that's a bit difficult to tackle. So I'd be very interested to hear today in these two sessions about ways of tackling smoking amongst women and also amongst people with TB. So addressing smoking and risky tobacco use should really be a priority for all services supporting people facing difficult health and life problems, but it isn't. And really, tobacco harm reduction is one of the simplest things you can do at a basic level. It's just telling people there are alternatives, but I know life is more complicated than that. So with that, rather more than a few words I was allowed to say, that's how I came to tobacco harm reduction, and I look forward to hearing today you discussing issues of smoking and tobacco harm reduction in couple of very important populations. So Tatiana and everybody, thank you very much.
Okay, thanks a lot. Thank you very much, Jerry, for this wider perspective and backwise perspective of harm reduction. And well, you know, something tells me that as it happened with drug harm reduction, it will happen the same way with tobacco harm reduction, that it will be the communities who will lead the change, the real life change for real people in concrete contexts on a planet. And with this, we are turning to our gorgeous and very knowledgeable, very experienced panel of presenters. Today with us, we have Evgenia Korotkova from Uzbekistan. We have Lyubov Vorontsova from Kazakhstan and Alla Besonova from Kyrgyzstan. All are tremendously experienced and prominent advocates and activists from their countries, known beyond the countries, and who have brought a lot of change for people living with HIV, people who use drugs and have other vulnerabilities. I'm happy to start this session with Evgenia's presentation on the triple stigma women experience in Uzbekistan because of different and complex situation they have in the country due to various reasons. Evgenia, the floor is yours. We are happy to have you with us today. This presentation will be delivered in Russian, so please get prepared for the translation.
Наверное, сразу надо проверить, работает ли трансляция сразу перевода. Потому что, да, у меня технически я не смогла подключиться, поэтому, коллеги, пожалуйста, проверьте, чтобы у нас
okay with the
было общее понимание. Ну, еще раз доброе утро. В моей стране уже достаточно день. Actually, later in my country, it's lunchtime, and here it's morning. So, good morning. Let me welcome you all. Thank you for your attendance, and thank you for organizing this forum, because HIV, women living with HIV have this opportunity to share our experience, our opinions, the opinions of our community. Unfortunately, it's not always the case that research takes into account personal experience. So some researchers focus on figures, on numbers. Figures is one thing, but it reflects a human being and a personal experience of a given person, and we shall do everything to support people. I'd like to share some of the results of our research on the experience of women living with HIV in the context of tobacco and nicotine use during pregnancy and after childbirth, and they used tobacco during pregnancy and after childbirth. Speaking of tobacco and healthcare, we usually discuss risks and statistical data. And we do not often hear the opinions of women themselves. Why do they do that? What are their fears? Why do they not refer to healthcare services and healthcare providers for help, for support? So today I'd like to share our experience, and I'm not only going to tackle the issue of tobacco use and nicotine use, taking into account the Central Asian context. We would like to tackle the issues related to what pregnant women or women after childbirth, what issues they're facing. I'd also like to mention a few words about our activities in Uzbekistan. We have the public organization for people living with HIV, and one of the areas of activities focuses on women living with HIV. And we are very experienced. We work promote access to services and going beyond the gender bias because there is the vertical transmission, of course, and in our country, one of the most important factors is the program on reduction of HIV transmission from mother to child, and we support access to services. We work in 9 regions of our country, and we offer community support to these women. Initially, it was not very easy for us to start working and collect interviews, for example, because of the barriers, because of stigma that interfered with our efforts. And I'm going to share our experience with us. One second. As I've mentioned, initially we faced the issue of the topic of tobacco as absent from HIV services, support during motherhood and after pregnancy, and those institutions dealing with prevention did not actually tackle this problem. So there are certain services based on protocols, there are screening programs as well available. But speaking of tobacco harm reduction, we didn't see any initiatives of this kind among the public institutions. So our research showed that women face a number of challenges on different levels we are going to discuss. So a woman herself, a woman who is a mother, and a woman suffering from diseases and HIV in this case, and who is using tobacco and nicotine. So this group is not targeted or was not targeted by official system. The context of such women was disregarded, and we hope that our research will give women an opportunity to speak up. Their voice is going to be heard because it's very important, and our voice will be heard by healthcare professionals and social services and welfare services providers. We've mentioned that healthcare system plays a key role in offering services. Unfortunately, we've seen that the system doesn't see the issue of tobacco use. In the majority of cases among our respondents, it was difficult to cope with stress, for example, anxiety, fears, emotional issues. And we have seen that there was some blame, judgment, and pressure on them, which does not limit tobacco use. It just makes this issue silenced and it remains hidden. So the system doesn't see these women and their needs and doesn't understand the reasons for such behavior. So, of course, when you receive a recommendation from healthcare professionals, the recommendation is one thing, and living in a family, hiding your tobacco use, for example, from the family members and from the surrounding the milieu. And when you actually raise your children, some women are single mothers, which makes this situation even more difficult, and they're facing stigma, which is multifaceted. And research has shown that when we interviewed our interviewees, this so-called triple stigma was observed, which means that they face several types of stigma, that they are HIV positive. This is one type of stigma. In our countries, we are facing stigma that a woman is HIV positive and pregnant, and the HIV status, and she's pregnant, and in addition, she uses tobacco. So this is the triple stigma: tobacco stigma, HIV-related stigma, and gender-based stigma. So there is a certain expectation that a woman should be healthy, first of all. This is the social expectation. And if she is unhealthy and has an unhealthy lifestyle, it is stigmatized, and there is this blame on her that she is the one responsible for these conditions. And of course, women do not speak openly about themselves. They do not disclose this information to their doctors, for example. We have also seen that our interviews mentioned not only the context of nicotine and tobacco. They disclosed information. They don't want to be seen as bad mothers from the point of view of neighbors, of healthcare professionals, and the milieu. So there was a lot of cross-sectional aspects. Many interviews had this experience of all types of manifestations of stigma in their lives. So when they accessed healthcare services, for example. We are aware that pregnant women and young mothers have their difficulties, and society has certain expectations as regards them. They're expected to be ideal mothers, ideal women, which worsens the situation of these women, and isolation is even deeper. Another important component is gender and control over women. We all know, and recently it has been noticed, It is on the agenda in many countries to deal with these gender-related issues, but awareness doesn't change overnight. It takes some time to change attitudes. Our research has shown that gender aspect plays a very important role. So when a man is smoking, this is one thing, but when a woman is using tobacco and is smoking, it is something different. For example, when she is pregnant or after the childbirth, she is morally assessed in a negative way. So she's thinking that there are stereotypes, and she has this burden during her lifetime. And if she's an HIV positive woman, she feels this social judgment. It's not only about health, also the issue of control over women was mentioned by our interviewees, that there are certain expectations, the way she should look like, what she should be talking about, does she have a right to make a mistake, or is she going to be blamed for any mistake. And an HIV positive woman does everything possible to give birth to a child without an HIV infection. So she takes care of her newborn. The focus is on a child, of course. This is the priority for every woman in general. What else? In the context of this gender aspect, women come across different social judgments, especially when she's pregnant or has just given birth to a child. And there is social and economic dependence or control. There are certain expectations women are expected to obey, and UN stays silent, for example. There are some other issues as regards control on behalf of family members, which aggravates the situation. So when control affects access to services and affects decision making, it is very difficult for a woman to decide about her health and her access to services. Her family controls her. For example, we sometimes have extended families, and women may be sharing a place with her parents, apart from her spouse, for example. So this is up to our tradition, to the national context, extended families, and you have huge respect to older generation, and spouses sometimes live together with parents and grandparents.
Therefore, a woman does not always have time for herself and to be for herself. As in our social setting, a woman is to keep the family and the house. She's there to take care of the health and well-being of the parents and of the children, and therefore there is not much time left for the woman herself. So the priorities are different. Therefore, once a woman feels this being judged all the time, and this judgmental setting is such that a woman finds it difficult to seek help. Therefore, as for tobacco harm reduction approach, it must be gender sensitive, and it must be based on human rights and respect to women. Now, what do we know from our survey? We have seen the main paradox. Perhaps that was the most potent conclusion from this research, that women are already motivated for change. They want to change. The research shows that in most cases, women were trying to reduce their use of tobacco. In most cases, women were trying to drop using, to quit using cigarettes and nicotine. And as I've said before, in their majority, and all of the women are worried about the health condition of their children. So the problem does not lie in the motivation of these women. They are motivated. The problem is different. It's about providing them with safe support. Once the system is judgmental, where there is a lot of moralizing, where there is so much judgment, these women do not speak openly. They're not being honest. In this research, we have seen what women say between the lines. As we were interviewing them, we received some messages between the lines, and in most cases we see that women wanted not to be blamed or intimidated. They want to be heard. They want to have a possibility to speak out. For me, this is the most humane type of research that we have carried out, where we have seen support begins not with treatment, but everything begins with a safe conversation. It turned out that so many women were not ready to come and talk to us. They were not ready to have an interview with us because they were scared. They had fears. And in most cases, we have been able to talk to women, but we have always heard about fatigue and anxiety. They're left all alone. They're not ready to talk about themselves and to talk about their needs. They're not ready to talk about their problems with other people, because they understand that they are going to be judged. So this research is a very important reminder. We need to remember that a person changes her behavior once that person is supported and not pressed upon.
Несмотря на нашу работу, и мы очень хорошо, то есть держим контакты, да, системы здравоохранения.
We are in good contact with the public health system. We are running many projects together with the public health authorities, especially in the area of maternity and childhood. Nonetheless, we have not seen that the topic of pregnancy, labor, perinatal period, and tobacco use are being discussed together. And if it is being discussed, then it's usually all about moralizing. But women were very clearly speaking about the big difference between a judgmental-based system and the support-based system. So they were saying how it was actually, and they were saying how they would like it to see. So the public health system may potentially increase trust, and so that people will be attracted to the system. But quite on the contrary, it may happen that the system may scare people away. One woman, once I spoke to a woman, and I asked her, describe your relations with the public health system and how would you like it to be? So that woman, she was very clear in what she said. She said it in very plain words. So when you go to visit someone, and you're welcomed by the host, or you're not welcomed by the host, right? So once you go to that house, once you've seen your friends, and you leave the house, and you immediately know whether you were or were not welcome, would you like to go back and to see this host, or maybe not? And that was a very simple description of how it feels. We want to go there and we want to be welcome. I simply need to have this desire to go back and return to that healthcare institution. It's just a simple example that shows the significance that people must be supported, people must be welcome, so that people want to go back. How about respect? Respect, love, kindness. Give them something to eat. It's, you know, give them a treat. It's like you go and visit your friends. And many women were describing some positive examples when specialists were indeed helping them, but there was so much negative experience as well. We understand it perfectly well that there is a reason behind all that. The human factor is very important. Yes, there may be some minor system bugs, and system bugs it could be easily addressed. We do not need to run some global program to fix a local bug. We have also seen that effective harm reduction is not doable without trust. Many times, these women also act as consultants, but also we need to take into consideration mental health of women. So use of tobacco, HIV, and maternity should also be integrated with the issues of mental health, so it all work hand in glove. It's not that we should be treating these areas separately, one from another. We should be comprehensive about it. And that's and that is clearly seen that harm reduction, it's not only about medical strategy, it's also about dignity. It's about giving access. It's about accessibility. And if a woman is open and honest about her nicotine use, then we may have a way forward. But if a woman cannot be honest, then we are coming up with some systemic problems. So we need to work on safety and trust. We know that harm reduction, it's not just saying okay to smoking. No, it's not that. It's about seeing the reality. It's just acknowledging the reality and acknowledging the needs of our women. So what do we suggest? First, we need to acknowledge that there is stigma and there is gender inequality. Those are main factors that have an impact on the health condition and access to services. Moreover, harm reduction should be integrated with maternity health programs and HIV programs. So it's all about prevention, because those are the places that women go to. So we need to work with the community of consultants. And the most important thing probably now is that we need to treat the healthcare professionals to be non-discriminatory in their approaches and communication. And we need to stop looking at those women through the prism of correct or incorrect behavior, conduct. And perhaps my last slide would be this one.
Это наша работа, и я решила ее тоже
This is
показать
our
и
work. The work
фотографии,
that we do. I simply wanted to share with you some pictures that show the way we work together with women and their children. There is a consultant, a medical doctor. In this specific case, we cooperate with gynecologists and obstetricians. And this is so important that a woman indeed is supported both by healthcare professionals but also supported by the community. We need to understand that any harm reduction must be gender sensitive. We should train our personnel, both the community workers but also the healthcare professionals, to be gender sensitive. Moreover, we need to provide for all basic services, provide all basic services for these women on the community level. So I have shared with you in brief the results of our survey. I will be happy to give answers to your questions, and you would be more than welcome to come and visit our sunny Uzbekistan, which is marvelous, which is beautiful. Thank you very much for your kind attention. I have a question. I am from Kazakhstan. I respect Uzbekistan a lot. I was to Bukhara last year. Yes, you have traditions at play. I would like... So, what do women use more? Do they smoke more, or do they use other tobacco, nicotine products? Well, let me describe that. In our case, we see that women use nasvai, usually nasvai, so that they're not seen, because there is no smell. So, if there is a room where it is not possibility to smoke, they use nasvai. But most of them actually use tobacco. But yes, nasvai is very popular. So, if as far as harm reduction is concerned, we need to understand whether they smoke or they use nasvai, and then to switch from nasvai to nicotine-containing pouches. So I think nasvai might be quite interesting here. And then the transfer to nicotine pouches. Yes, you're correct. But unfortunately, today's legislation in Uzbekistan is such, there is a ban. Yes, there is a ban. Yeah, that happened recently. I'm speaking about Uzbekistan. In Uzbekistan and in Kazakhstan, they also banned. No, I'm not talking about nasvai. I'm talking about pouches. Pouches have been banned.
Thanks a lot, Evgenia, for your presentation.
Благодарю вас. Большое спасибо, Евгения. Благодарю вас за вашу презентацию. Вижу, что у нас еще есть несколько вопросов в зале. И будем же, конечно, отвечать на ваши вопросы после всех презентаций.
Огромное спасибо за презентацию. Мы увидели, что это основано на конкретном опыте. Мы увидели, что курение связано с целым рядом факторов в Узбекистане. А теперь Алла Бессонова,
The right questions asked by the communities in safer environments. Alla Bessonova is a veteran activist from Kyrgyzstan with a lot of achievements, and she, including the International Jude Byrne Emerging Female Leader Award in 2024, and we are very happy and honored to have you with us, Alla. The floor is yours.
Before I start, I want to pay attention how important is to make community-led assessments and researches, and what we can find when we use community-led approaches. I want to start with a single number, 26. Что происходит? I want to start with the single number 26. This is how many times higher the smoking prevalence is among women who use drugs compared with women in a general population in Kyrgyzstan. Not twice, not 5 times, 26 times. For men, the difference is only 2.5 times. This means the gender gap in smoking, men smoke more than women, virtually disappears in our group. Women with drug addiction smoke almost as much as men. Our work in harm reduction program, and we know our clients' HIV status. We know what drugs do they take. We know their history, but we never ask them about smoking. And I also want to tell you now one quote. Women who was participant in our research. She told, "I know I'm destroying myself every day, but I simply can't calm down without a cigarette." The Data Attica 2025 researchers is the first research of nicotine use among people who use drugs in Kyrgyzstan. Few key figures: 26.8% of women using drugs in NGO-based harm reduction programs smoke, compared with roughly 3% of women in general KG population. 26 times higher, that is a gap for women. For men is only 2.5 times. 11.3% of women use vapes, compared with 2.7% of men. Women are already looking for less harmful alternative for their own. 5.4% of women use heated tobacco products, again higher than men at 1.9%. What does this tell us? Women in harm reduction programs are far more actively seeking less harmful alternative than men. They are not passive. They are looking for solution, but the system is not help them find one. Now why? This is not simply a habit. Look at the data. 81% smoked because they are addicted to nicotine. 80% to manage stress, expected. But here is the expanded part. 59%, more than half, smoke because a cigarette enhances the effects of drugs or reduce side effects. I think this is not psychology. I think this is pharmacology. Nicotine and drug interact at the neurochemical level. That means you cannot address smoking without addressing drug addiction. One more figure. 29% smoke to feel social connection. Smoking is a ritual of belonging. Programs, they simply say, just quiet, ignore, or completely. Они переключают. Что случилось? Нет. Пятый слайд. Еще. Ага, спасибо. Okay. One more. I'd like to mention these women know perfectly well they smoking is harmful. They know, but 79% feel they should not be judged for it, and they are right. But here is a critical point. 61% believe the effective help them quitting simply does not exist. And 47% thinks you can only quit without willpower. Professional support is not needed. This is not ignorance. This is a rotation response to a system what has adapted them. If the system never offered them real support, how would they know it exists? Particularly striking, 50% believe that quitting smoking during rehabilitation is dangerous for their sobriety. It can be assumed that this is perspective among people who use drugs in a consequence of lack and accurate information about the interaction between drug use and smoking. How they try to quit. This is the most revealing slide for understanding the system failure. 85% try to quit on their own, without any help. This is not a choice. This is the absence of choice. Government services are effectively closed to this group because of fear and stigma. 33% switched to vaping, and it worked. They found the solution themselves, but from 1 July 2025, vaping is banned. Only 5% use a psychologist or cognitive behavior therapy. The tobacco quiet line was used by 1%. Almost nobody. Not because they don't want, because they don't know about it and don't trust it. Context. Kyrgyzstan has done a great deal for harm reduction. Since 1999, needle exchange, methadone therapy, HIV testing, genuine achievement. Formally, a support system for smokers exists too. The Republican Health Center, which a 24/7 quiet line, tobacco's recommendation, but for our women, this is not work. They will not go to governmental center. They fear disclosure, registration, police, and no tobacco harm reduction programs adopted for people who use drugs. Another change in Kyrgyzstan. In November 2025, the law was adopted banning vapes completely from July 1, 2025. Fine for an individual around $115. Our data shows that 33% of women used vaping to quit smoking. It worked. The pathway is now closed by law. IQOS, the only legal alternative, cost between $31 and $72, with an average incomes of $345 per month. That is about 21% of monthly budget. The option is not available on a permanent basis to women who use drugs who are unemployed. Why don't women seek help? Not one barrier, an entire stack. First, drug use stigma. fear of police registration. Second, gender stigma, bad mother, immoral woman. Finally, reinforced shame, not support. Third, the stigma is smoking women, especially in Osh, where speaking about this openly is nearly impossible. Zhenya also represents the situation in Uzbekistan. It's similar, same in Osh, because they are bordering. On top of all this, poverty and the law. No affordable alternative, no trust in governmental services. Women, no one asks for help. They continue to smoke. And now, the important part, what we do not know. We do not know how many young women aged from 18 to 25 in Kyrgyzstan use synthetic new psychoactive substances and smoke. In our sample, 13 of 35 young women were in this age group are significant share, but no representative data exists. We do not understand how methadone, alpha PVP, and other synthetic substances interact with nicotine addiction. Some synthetic substance and new psychoactive substances suppress the urge to smoke. Other dramatically amplify it. No systematic research exists. And also one quote from women who participate in our assessment. She told, after methadone, I don't feel like smoking at all. It just disappears. But with heroin or methadone, it's completely different. Then I start smoking strong cigarette to intensify the effects. Think about what this means. One substance suppresses to urge to smoke. Another amplifies it. The approach, just tell her to quiet, is completely meaningless without understanding what she is actually using. An interesting finding on Naswai. 25.6% of men in our study use Naswai. Among women, 0.5%. Why? Stigma. This is unknown. And finally, what works for women in Osh, where stigma is at its highest? We documented the gap. We don't have the answer yet. Despite all of these changes is possible. Our assessment ran its own pilot. 55 women, 3 months vapes plus trainings. The result of 3 months our work, minus 45% average reduction in cigarette smoked after access to vape. 60% changed their attitude towards smoking. 75% reduced consumption after cognitive behavior therapy and training, where participant 30 women. Three women completely quit combustible cigarettes and switched entry to vaping. What worked? 3 principles. First, fear-led a peer-led model, not a clinic. Zhenya also told about this. Women don't go to doctor, they are afraid. People from community, they told that they are their own doctors. They don't listen people from medical structure. A peer counselor, their trust. The peer research, thus the system could not. Second is a cognitive behavior therapy plus a real tool, not lectures. Cognitive behavior therapy shifted the thinking. Vaping gave a concrete instrument. Without cognitive behavior therapy, vaping doesn't hold. Without vaping, cognitive behavior therapy stays theory. Together, result. Third, age-specific personalization. We run separate training for women aged 20 to 26 and 40 to 47. Younger women, reproductive health risks and hormonal context. Older women, hormonal changes and chronic illness. One program for everyone is not working. And also I want to share one quote. After the training, I realized I could manage stress without tobacco. That was an important discovery. Vaping can be not just a change of habit for me, but a way to regain control over my health. And the last slide. Let me close my presentation not with 3 recommendations, but with 3 questions recited at everyone in this room. First, if you work in harm reduction, when did you last ask your clients where they smoke? It takes just 30 seconds or maybe 1 minute, and it could start a conversation they have never had with anyone. Second, if you work in policy, the vape ban protected those who don't yet smoke. But what does it do to a woman who already smokes a pack a day or uses drugs? Is there an answer to that question in laws in different countries? If we are researchers or donors, young women using synthetic new psychoactive substances are the least studied group in Central Asia. Almost no data and no programs. Thank you.
Thank you very much, Alla. Striking data. What can we say? It is now my pleasure to introduce to you Любовь Воронцова.
Получаете данные и предоставляю слово госпоже Любовь Воронцова из Казахстана. Она активистка, и она является ключевым
Efforts to help people with HIV and to fight for the rights of other vulnerable groups in the country. The floor is yours. You're welcome.
Thank you. Thank you for service for short people. Hi, and thank you for your passion. You know, I really appreciate my colleagues from Kyrgyzstan and Uzbekistan because we already know about the context, women, HIV, and drug using. And that's important. And in my presentation, I will try to keep the focus for actions and give you help. And first, it's a little bit numbers about Kazakhstan. I don't want to say about all numbers, but it looks like really similar that we saw in Evgenia's and Alla's presentation. And just one thing that I want to keep the focus to, the most of anti-tobacco campaign in Kazakhstan is focused to young people and general population. It's important that when I follow up in my presentation these things. Another thing, it's like the same. We have a lot of smokers. We have a lot of women who use tobacco in Kazakhstan. And yes, this is the numbers. And of course, first step that we should do when we want to do some action, we need to know about the needs women. And this is numbers that we do, how we did this, how we follow to needs, and how we take this information in Kazakhstan. And the key funding was really the same that Alice Evgenia said. It's like it's all about it's all about the coping mechanism, fight to stress, and gender stigma. We all here in the same level with our neighbors. Yes. And but I want to focus in the one main things that my colleagues already mentioned about information, about the safe places when women can take this information, where women can discuss it about their experience and how they can do some tobacco harm reduction, about this. And what we saw in our assessment, the women reported a lack of non-judgment communication and safe places to discuss smoking, stress, and quitting. This is important. And breaking the don't talk about this rule should become to one of responses to this problem for women. And this is how it's look, yes. It's like one of gaps. And what I want to share with you about how we started to do action. And you know, when we talk about community-led assessment, you know, community already started to did some actions when they started assessment. And of course, first step, it was education. Education per consultant. And we used to some online courses, yes, academic tobacco harm reduction, which was very useful for our peer consultant. I really recommended this. And second part, it's a face-to-face meeting where we're talking about the harm reduction approaches, gender-sensitive services, stigma, stress, and communication strategies for women living with HIV and for women who use drugs. And we also thought about the one of topic, very important topic about, for example, reproductive service. Nobody thought with women about this when, how Evgenia said, it's like a taboo. Women who in pregnancy can be women who use tobacco. And this is like very important. Next part of education, it's like peer-to-peer support and consulting. Our peer consultant go to the women and women living with HIV and women who use drug in their cities, and facilitating safe discussion about smoking, stress, dependence, and harm reduction options. And next step, it's like we are development community-led information materials for these women, where they can take some information about harm reduction options. And this is like example how it looks like. We created some videos, materials about women experience, and we created the guide for women living with HIV, women who use drug, with simple rules how they can take some option what they should do if they want to reduce their harm from tobacco using. And this approach successful because there was already an existing infrastructure of peer counseling working on HIV and harm reduction for people who use drugs. You know, we already have infrastructure. We just need to add another important question for these services. And that's why it's work really good for our women. Yes, and this is campaign based in materials, based in data collection from community-led monitoring of women. And this is important too. It's like an answer to questions that women give us in this assessment. Yes. Here is a small video, but we don't have a time for it. But the women in focus group shared with us their experience, and now this experience is like based on our information company. Yes, and what is the key takeaways? We should know how my colleagues, my sister from Central Asia said, women living with HIV and women who use drugs have a specific tobacco harm reduction needs. We saw that in this presentation, and this is very important. Smoking is closely linked to stress, stigma, and emotional coping. And peer-led, community-based approaches are the most trusted and acceptable way to discuss smoking, quitting, and harm reduction for women. And of course, HIV and harm reduction services can improve access to information, support, and healthier choices. And this is important, yes. Okay, I'm over. Thank you for your question.
Thank you so much, you both. So we have just heard that a lot of women are actually aware of the harmfulness of smoking. We don't need to tell them that. We need to create safe spaces and actual access to real treatment and real help with all the multiple issues that they have in their contexts. We will now take a couple of questions from the audience. So if anyone would like to ask our presenters, please do it now. Yes.
Yeah, I think the presentations were really very nice. It was driven by the data impacts, and it was kind of learning for me because this was something that was new. I have worked in HIV and TB, but the tobacco intersection with the people living with HIV was something very much new and learning. My question is that in India, it's a home of people who use drug or tobacco in different forms, right? In India, women who use drug or inject drug are forced to kind of, not forced actually, they are encouraged to take another alternative substance, like for example, opioid substitute therapy, OST, in the form of methadone or buprenorphine, right? But many community members in India, they think that if they want to quit the injecting part or the used drug part, then they should start smoking because that is the safest thing. And people in India, people who are in HIV response, the ultimate objective for them is to stop the transmission, right? So they also don't, like stop them to not to kind of, start smoking, but do something else. If not injecting, but then something else. So how, in that context, we as a community members or the network of the civil society can intervene and can provide that information is also important, which has never been talked or discussed. Is there any way that we can do something like this? Thank you.
Thank you for the question. Any thoughts about this?
I'm already answered your question in my presentation. You know, it's like for community, it's always important to have a place where they can safely talk about the experience without stigma and discrimination. And for example, in Kazakhstan, we created some chat for women. They can share about experience and learn each other, how they can go to quitting or less harm from tobacco. And for example, one of our peer consultants, she is from Astana, and she was quitting the tobacco during our assessment, and she shared it about the, and she followed from our guide. That's for example, just break the rule, we can talk about it. Even in program harm reduction and drug user, we don't have any information about how it's harm. And what you say about the when I started to use drugs, I should start to smoking, and if I stop to using drugs for the same time and have a remission, I should stop the smoking, but I can't, and it makes stressed. Yes. And this is the same in our country that I heard you. It's like, this is like, I think we're all in first step. Just start to talk about that.
And for doing this, I would note that the already existing, very grounded infrastructure that you have created through the decades of your work helps a lot now with addressing tobacco issues in people. We had one more question here. You're welcome.
Actually, I have rather a comment as a question. I have to say that it was a great presentation. Thank you, Evgenia, Luba, and Awa. And my small question is actually, as you mentioned that the women in your countries are very stigmatized for the smoking. Is it the same by the men or not?
Yes, indeed. We are living in a patriarchal countries, and in Central Asia, it's specific. It's changed from Eastern Europe because of Islam religion. It's also women smoking. It's also depend on it, and it's became more and more in our countries. It's something. It's really depend on it, and yes, it's really about men. That women cannot smoke, they cannot use drugs, they cannot make something with their bodies, and etc. etc.
Thank you very much. We have now run out of time, unfortunately. I suggest we continue conversations during coffee breaks and further meetings today and the rest of the conference. I thank you all very much. We have heard just very striking and invaluable insights from the communities, and I do believe it will help us build meaningful, rights-based and context-related and gender-based activities for women who suffer most from multiple vulnerabilities in their lives. Thank you very, very much, and thanks for the audience for listening to us and supporting our presenters. Thanks a lot. See you soon after the coffee break.